can start. So welcome on behalf of Andreas Ulrich and me on the World Health Summit, and it's tradition that we try to talk about capacity building. And I'm even proud that Andreas Ulrich joined our research and clinical community to bring experiences to this panel and to this field, because it will be maybe the backbone of our session about capacity building for excellence in healthcare for women. And I like only to address as a gynecologist, as a gynecologist directly from the European Society of Gynaecology in Prague, that women health and women cancer is maybe one of the most relevant quality indicator for every healthcare system. And based on the crosstalk with the COVID-19 pandemic, yesterday we already discussed it with the colleagues from WHO. We'd like to address that action is really needed and we need to learn from the lessons. And that is, I think, what we like to address today, to share experiences about global challenges, global responsibilities, global networking, and even individual responsibilities. And I'm really proud to co-chair this. And Andreas, again, thank you personally to you, to your personal engagement to bring this outstanding panel together to make next steps visible. So thank you, Andreas, and I hand over to you, please.
Thank you, Jalit, to Prague, virtually connected. I'm really also very excited about this panel. We at the World Health Summit have three pillars, and the big pillars of we want to support World Health Summit with these three pillars. So it's called global challenge, global responsibilities, and global networking. And the World Health Summit is more and more an international, worldwide center of gravity for global health. And we contribute with the angle of women health, and our specific focus today is increasing capacity to deliver excellence in healthcare for women. We know that women healthcare services are very much limited in the global south, but also in high-income countries with disadvantaged populations, and several factors are playing a role. One of them is tremendous educational and skill training gaps in healthcare providers. What is our global responsibility? We see more and more a divide between research and development of and innovation in healthcare, in medicines, in technologies, in IT, in intelligence, artificial intelligence, but these are not spread worldwide. So we have to make sure that the advances, and without any doubt, there's a lot of advances in medical care of women conditions, are spread around in an equal manner, and we have to contribute to that. So, and global networking meeting is to bring, and just mirroring what Jalit has introduced, we have to work together across silos. And this is the opportunity now with this very distinguished panel. I would like just to go around who are our panelists. Sarah Nasser, colleague from Berlin at the Department of Gynecology and Gynaecology. She is a clinician. She works as a clinician and is dealing with hundreds and thousands of patients. But beside that, she is the executive officer of an association of specialists, the Pan-Arabian Research Society for Gynaecology. And she is leading a specific e-health program together with the German government, the GIZ, ISTAG program, a North-South capacity building project using digital platforms to improve care for women. I have on my panel my friend and former colleague from WHO, Jean-Marie Dangou. Bonjour, Jean-Marie, to Brazzaville, connected virtually from Brazzaville, Congo. He's a medical doctor, has been working for more than 15 years in the WHO regional office for Africa, Brazzaville, is currently leading the NCDL, the non-communicable disease management program. So he's interested what we are doing in cancer and other non-communicable diseases in charity and worldwide. Jean-Marie is specialized, is a professor, a university professor specialized in histopathology, cytology, and epidemiology. And then I would like to introduce Rupa Dutt, who is physically in Berlin. That's something, a chance. But she's a medical doctor. She's really also with this hybrid function to do clinical practice and to global health in Washington, D.C. She's executive director and co-founder of the Women in Global Health, and her focus is health workforce and to enable women work in the healthcare system to have better conditions. Her focus also is gender equity and universal health coverage. Thank you for joining. And then we have Tanja Breiker, who is also physically in Berlin, but not in the same room, because she has joined from her hotel, I think. So yeah, Tanja Breiker is vice president of an important company which has very much focus on women health products, which is called Hologic. Tanja Breiker joined Hologic in 2018, but she's also a trained nurse and midwife. She knows very well the groundwork of nursing and midwifing, and she has had several senior leadership positions in healthcare companies, and she is passionate in advancing patient outcomes through quality, medical innovation, and excellence. So she is fully online with our purpose to join efforts to develop health workforce for excellence in care. Now I would like to start with Sarah Nasser with the first question: how tailor healthcare provider education to women health needs? Sarah, you have 5 minutes. The floor is yours.
Thank you very much, Andreas. Thank you very much, Andreas. Thank you very much, Professor Sibuli, for this invitation. It's a pleasure to be able to speak in such a meeting. Sorry, we're sitting all in the same room, so we need to get, yeah. You're muted. Okay, excellent. Right, everybody can hear me well now, I hope. I hope this doesn't count to my 5 minutes. Technical difficulties. So again, I'm very pleased to be speaking in such a group and to such a esteemed audience. Yes, so I'm a gynecological oncologist, and the focus and the question is always how to tailor healthcare education to the healthcare needs of women in low and middle income countries. And these are really the countries that we're partnering with. In my opinion, and from my experience, the main building block is really commencing and maintaining continuous dialogue and exchange within the region. And this is done through strong partnerships with clear goals: innovation and access. So these three things. The strong partnerships, really what we see is that having clear goals within the partnership is really important. So what are the main healthcare needs in the partner countries? For example, screening programs, or no standardized training in gynecological oncology or in surgical procedures. We need to have a direct and honest dialogue, not just at a physician level, but at a transdisciplinary level, and to keep that approach direct and honest with clear goals. And this is really part of a change management movement, and it should be the cornerstone for building strong partnerships that are based on a two-way dialogue. The second point is innovation. So innovation is very important, and this is what most of my projects are based on. The term digital health technology has been discussed at length yesterday and is a hot topic at this Congress in general. And we were just speaking about this at lunch just a few minutes ago. Innovation is key because it increases visibility through digital health technology, increases outreach, and you can measure impact. And so this is how you can tailor what educational needs are present in order to improve the healthcare for women in low and middle income countries. So for example, in one of our projects that we do, we can actually measure how often certain healthcare providers click on specific subjects and what videos they watch, etc., so that we can then target our educational videos and our educational programs to their needs. And this is really the term that I like to use, is targeted education. The same as we use targeted therapy in cancer treatment, we need to also use targeted education, and we can do that through innovative technologies. And the third point is access. So there's no point in having the best digital technologies and digital healthcare when healthcare professionals are not accessing these measures, or they're not able to access these measures. So through digital technologies, we can make it easier, and we can cover a wider and a broader region. And these are really my 3 points. So strong partnerships based on clear goals, innovative technology and the use of innovative technology, including social media, and access to healthcare education.
Thank you very much, Sarah. This is a fantastic introduction also to hand over to Jean-Marie Dangou. Jean-Marie, the WHO regional efforts to get NCD into the agenda of national programs. What is the component of human resources for health for NCD? What is the WHO's say in that direction? Over to you, Jean-Marie.
Thank you very much, Andreas. I would like also to extend my appreciation to the organizers of this session. And also, I'm very delighted participating in this panel discussion with very estimated and strong colleagues. First of all, it's important I share with you the situation in the African region, where women need health care for their reproductive and sexual life, but also for chronic non-reproductive health issues, such as cardiovascular diseases, breast cancer, cervical cancer, menopause and pregnancy, but also depression, anxiety, diabetes, osteoporosis, as well as infectious diseases, such as sexually transmitted disease. As you can see, gender inequity, poverty among women with economic capacity, sexual and gender-based violence, including female genital mutilation, which is really an issue in our region, are major impediments to the amelioration of women's health in the African region. Based on my experience on the ground, I believe that primary care providers are best positioned to impact the quality of care at the source. When used correctly, I think primary care providers can act as the hub for a patient-centered care, focusing on women. I would like to suggest, as said by Sarah, a targeted education based on the 5 following steps. First of all, at country level, if we want to support them, we should align to their needs. And so countries should collect data and analyze patient outcomes, here focusing on women's health. The first step to improving the quality of care is to analyze existing data to understand where opportunities exist. We should analyze both women population, our women population, and our organizational operations to identify area for improvement. Then use this data to establish a baseline for healthcare providers' education and patients' outcomes. It's important to identify the wealth of available data and IT-based systems or to enable more patient-centered connected care. Second, The second step is to set goals for care providers' education and commit to ongoing evaluation. That's also a very important step to be taken at country level. The third one is to improve women access to care. Most of the women population have a dramatically reduced access to timely care, making them go without preventive or primary care. It forced them to rely on higher cost and therefore lower value services. Today's health care system is far too fragmented to serve women well. The fourth step is to focus on women engagement. Women can be the best advocates for their own health, but first they must be engaged and taught to be proactive healthcare consumers. This is not an easy task, but it's one that primary care providers particularly should be well prepared to undertake. The fifth one is to connect and collaborate with other organizations. And that's where we should come in and align our support to what has been defined at country level. Healthcare organizations that truly want to improve the quality of care should regularly research and learn from other organizations, go back to those areas of improvement you identified and goals that you set, and look other healthcare organizations that excel in those areas. Most organizations are happy to share to improve the lives of all patients, including women. So I'm suggesting a bottom-up approach instead of a top-down approach. That's back to you, Andreas.
Thank you very much, Jean-Marie. Your last 2 minutes were not transmitted, but I think we already can take your 5 points. You could communicate it through the IT channel. So one lesson learned from this is that we have to strengthen our IT platforms worldwide so that we can interact. In the lunchtime, it's a fantastic opportunity also for Rupa to come in and to say what the civil society can contribute and how data-driven approach is extremely important. Rupa, over to you.
Thank you, Andres. Okay, testing. Okay, great. Just I think there's no echo anymore. So building on what my colleague said and really bringing the perspective of women in global health. So we are a global movement that has over 40 chapters around the world. Majority of our chapters are in lower middle income countries. We focus on advancing gender equity in health, and this agenda, especially how do we tailor healthcare, provider education to really women's health needs, is a core aspect of critical work we're doing. So I want to start with 4 really key points. The first is we have to start changing the narrative and start viewing women as leaders. Too often we see them as only vulnerable populations, recipients of care. And so if we are really trying to, again, engage them in a education agenda, which is about women's health needs, we need to start changing the narrative. The second is we too often focus on fixing women and not really fixing the systems to really create the enabling environment for them to engage with their health system, to engage with their health education, to increase their health literacy. And it's pretty widespread. And so one of the special initiatives that we're doing at Women in Global Health in partnership with the World Health Organization and the government of France is called the Gender Equal Health and Care Workforce Initiative. It is aiming to really focus on advancing gender transformative policy. And when we say gender transformative, what we mean is not only just acknowledging that gender dimensions matter, but going to the root drivers of why gender inequities exist. And particularly when we look at the health workforce, we know that 70% of the health workforce are women. When we look at leadership roles, only 20% 85% of those leadership roles go to women. But even in the COVID-19 times, we've seen that women's expertise has been completely sidelined. They're not in decision-making roles, and women are often clustered into lower status jobs, facing violence. Half of what women do in the health sector is currently unpaid. So this initiative that we launched this year in February of 2021 is really trying to bring together 4 key pillars of advancing change. One is on leadership. So we're calling for women to have increased leadership opportunities, and for governments and all stakeholders to be very intentional of making sure that women are at decision making at all levels of the health system. So that's one way we can change the narrative, view women as leaders, and really have a systems approach. The second thing is really around addressing the pay issues. The gender pay gap is very high in the health sector. It's about 28%. When you compare that to other sectors that are only 20%, we also know that women's contributions is often in the unpaid form as well. So that's another pillar that we're really trying to advance. The third is around violence. We know that there's a lot of violence that women face in the health sector, and the violence can come from patients, can come from colleagues, can come from communities. This is sometimes reported at least at 50% of some form of sexual harassment, bullying. So the third pillar is saying, being mindful of like, how do we create enabling environments? Again, women as patients often are worried about their safety, so will not access health services, but also women that are delivering health services are worried about their safety. And so this is, again, hampering our ability to provide care. And then finally, the fourth pillar is what we call having safe and decent workplaces. And this is where we have the agenda of really having decent work, making sure that all health workers have access to personal protective equipment, they have mental, psychosocial support. You've probably heard the numbers that many health systems are predicting that at least 20% of their nurses will leave because of the mental health issues and the burnout they're facing. So, in changing the narrative and fixing the systems, the third part, which Andreas also alluded to, is the role of data. We know there is a massive data gap in health. We know that a lot of the data we're getting is not disaggregated in the ways that we need it to be disaggregated. We're really calling for sex and gender disaggregated data, but also making sure we're collecting data on issues such as women's representation. Where are they present in the health system? What leadership roles are they having? Disaggregating it by health workforce cadre, for example. And we also know that in the data space itself, many of the clinical studies that have taken place have been on men. And so how we even understand medicine, how we understand diseases, and the classic example is if you're having a heart attack, and I'm a physician, and we've been taught in medical school the heart attack is left-sided chest pain with pressure, crushing, a lot of sweating and nausea. I mean, these are symptoms that men present with, but we describe women's symptoms as atypical, and actually women are majority of the world's population. So I could challenge all of you and say, actually, isn't it atypical how men present? So that's just an example of how we need to have clinical studies and the research disaggregated by gender, and really understand how diseases present, how diagnostics work, and how treatment, and then the overall progression of disease by gender, and really integrate this into our education. And finally, I'd like to say on the fourth point is we must start applying a power lens. The reason why our health systems are designed by men for men has to do with the history. We need to start looking at decolonizing is one terminology that's being used in global health, but I think it goes into really looking at a power lens to see the people we're trying to reach. In this case, it's women that we're talking about. Are they really in the driver's seat of setting the agenda and able to drive how healthcare reaches them, and whether or not we're touching on the issues that matter the most to them? So, on that, I'd say, the 4 points are: change the narrative. Second, fix systems, not women. Third, really look at disaggregated data and investing in research and development in a gendered way. And fourth, really applying a power lens.
Thank you very much, Rupa, for this comprehensive and short introduction of what your organization, what you want to convey to our audience, and how we can really make a difference. And now I see that we have another speaker. Our friend and colleague from Turkey is joining. That's fantastic. that you will contribute from ESCO.
Yeah.
Murat Gültekin is a gynecologist, and he is the chair of the prevention committee of the European Society of Gynaecology. Murat, would you address a couple of minutes about what ESCO is doing for education of healthcare for women? Over to you.
Thank you so much, dear Andreas. First of all, it's so pleasure to see many of our friends here. I am learning every day different perspectives, different statistics, and all these types of webinars is a very simple example. How should the healthcare provider like me should be educated? So I see different perspectives, and so happy to see the numbers that I have heard from Rupa, to see the perspective of WHO. So what I do believe is this should be a continuous education, and including different perspectives of different stakeholders, different ideas, and different approaches. The question for me, if you are talking about the female health, who should be the principal health provider? First of all, we should define really a health professional who should take care of each lady, each woman. In some countries, this can be a gynecologist like us, because at least all women, anyhow, during even labor, do approach to a gynecologist or obstetrician. In some countries, this may be a GP. GP, you know, in our country is the best model because we separate 2,000 ladies in a street per each GP. And in some countries like Africa, maybe, where you don't have any GP, you can move with some nurses or health technicians. This is also possible. So firstly, let's define a core group who would really take care of the women's health. And I believe this should be best trained with new IT solutions. This Corona, what teach us is online telecommunication is really fantastic, and we can have different modules for everybody. From the ESGO part, we really had more training during COVID period compared to pre-COVID area. Almost now we have 3 to 4 webinars per week, and these IT solutions should be really modulated to the modern area in the world. And the second point from the ESGO, we have the patient groups, patient advocacy groups engaged, and Jalit Sehuli now is the chair. But I told you different perspectives, perspective of Jean-Marie from WHO, Ropa and Sarah coming from Middle East. But we should never forget the perspective of the women. So what do women think when you call her for HPV vaccination, HPV DNA screening? Is she happy with your system? This is my Turkish experience. Many Turkish ladies were unhappy. You can think, oh, it is a conservative surgery, the ladies are not coming. No, they are unhappy with this screening system, with the available invitation, using several IT solutions that clears the pathway, referral pathway, that clears to go to hospital just to learn a result, and makes the ladies very happy. And we had a 10 to 15 times increase in cancer screening with just simple IT solutions. So the lady in the home can make self-test, can learn her result from a cell phone, and can easily have an appointment to the closest colposcopy center. So this is what ESGO teach us. The patient perspective should be definitely included in all training modules. Secondly, IT solutions is the best solution for training. The third point, every country, as Jean-Marie said, should define a core group. This can be a nurse, a health technician, a GP, a gynecologist. But these guys should follow up the ladies. It's not only one-time examination per life, but to call her every year or every 2 years or every 5 years. So this core group is very important to monitor what is going on, Andreas.
Thank you very much, Murat, for this very concise view from you, from the organization of the gynaecologists in Europe and worldwide. Thank you very much for this message from inspiring message from Prague. And I would like now to hand over to Tanya Breiker. Tanya, we have heard a little bit about the Women's Health Index already at lunch. I'm convinced that you will spread the message of that data, treasure of data now to our audience from the World Health Summit. Tanya,
Yes.
the floor is yours.
Thank you very much. And just to check, everyone can hear me okay? Perfect, excellent. Well, thank you very much for the opportunity to participate in this panel today. And yes, I am very excited to be the representative from Hologic that brings the Global Women's Health Index to light in this and other discussions across the course of the summit. A lot of what I'm going to say today, I think Sarah, Rupa, Dr. Nago, and Jalid, Murat, you'll all see some parallels to what you've said, but equally, I hope it also provides a slightly different structure, perhaps for us to think through and with the audience to consider. So at the start, what I'd like to say is that my comments today are coming from both being an executive within Hologic, which is a commercial device company, but also from my experience as a midwife and a nurse. So I'm trying to blend both in terms of the recommendations that you've asked us to provide. To the first question around recommendations for provider education, I think that there's 2 layers to this, and that is addressing both patient and provider education. Both are key to meeting the needs of women's health moving forward. Healthcare provider education absolutely is part of an overall program of change and pivotal if we're going to create sustainable improvements in women's health. At the same time, educating women on their health options is also vitally important in order for us to help them gain awareness of what is available to them, as well as gain their trust. There are 3 key elements to what, from an index perspective, we've been able to define. And one is that research and data is absolutely pivotal to us building a type of program which is going to move the needle for women's health. The next is around access to care. And then the third is around awareness and education. So if I just focus on the piece around research and data, Hologic has driven 2 very specific and significant multifaceted and multi-year projects. One is called the Hologic Global Women's Health Index, and the other is Project Health Equality. Both are important to this discussion today. The Global Women's Health Index, just to give some highlights to this, you can find free copies across the summit, and you can also download it for free from our website. The Global Women's Health Index is the first global survey that draws from women's perspectives to provide a baseline from which we can measure the status of women's health now and into the future, and determine the priorities by country. It's representative of around about 2.5 billion women and girls. It's based on the experiences and the direct feedback from 120,000 men, women, and girls last year from 116 different countries, and it's captured in 140 different languages. As I said, it's a multi-year program. We are repeating it now, and we will continue to repeat it across the coming year. Out of the index, what we've been able to identify is there's actually 5 dimensions for women's health, which can explain about 80% of a woman's average life expectancy at birth. And Dr. Nango, you probably will hear some similarities here from what you had to talk about. Those 5 dimensions, the first one is access to basic needs like food and shelter. The second is around individual health and how pain, for example, is managed. The third is around emotional health. The fourth is around opinions on health and safety, and that's general and maternal health, as well as safety at night. And then the final one is access to preventative care like breast and cervical cancer screening, just to name two. The second project that Hologic is working on, Project Health Equality, and it speaks specifically to the education topic, is a program that combines data and research, education and access in order to address the structural and the cultural barriers that impact women in particularly disadvantaged communities. The goal of Project Health Equality is to innovate culturally competent care, improve public health policy, increase awareness amongst women in those communities, and allow them to drive access, and ultimately to decrease the disparities that lead to disproportionate morbidity and mortality for women in these disadvantaged communities. To date, our focus has been on some communities within the US. This year, we have 2 pilot programs running, one in the UK and one in Canada, and we're looking to expand those programs across the course of the coming years. To the previous speaker's commentary, there are disadvantaged communities in every country. It doesn't necessarily need to be a second or a third world country. But to come back to the question around the broad 3 pillars about meeting women's health needs that flow into our recommendations for healthcare provider education, it has to be based on research and data. And that data needs to recognize the cultural and social and economic disparities that prevent women from accessing and receiving care. Only when we have that data can we then design the programs that are going to help both healthcare providers and women understand and engage. The next is around access to care, and the data gives us insights. Partnerships help us to transform the delivery of day-to-day care for women, whether it be for breast and cervical or any other type of service that they require. And the final piece around awareness and education, coming back to the central question, was around, from our perspective, we're looking at developing and disseminating communications inspired by the research and the data to ensure that healthcare professionals, providers, policymakers, others can identify and implement the solutions that are needed, as well as for women to drive the education for patient awareness, to encourage them to trust and engage with screening programs, for example. That's all at the heart of improving health outcomes and at the heart of any education program that we put together. So to summarize, our recommendations to the question is to learn from and incorporate what the Global Women's Health Index is telling us, to use research and data to revise and build the dedicated programs that address women's health disparities in each country, and finally, to enhance cultural awareness and education by partnering with communities to build trust, drive acceptance, and in particular, access.
Tanya, thank you very much for catching a huge report in a couple of sentences. It's fascinating. And what was thrilling me is this statistical, but data is statistic first, and then it's life, that life expectancy is explained by a couple of opinion, let's say, perceptions of women's perception of the healthcare. That's completely new, a new knowledge about relationship between behavior, between well-being and life expectancy. I now would like to hand over to my co-chair, Jalit, who will guide us to the next question. Jalit, are you there?
So, thank you. First of all, I'd like to, thanks to the dialogues. And I think if we talk about challenges in digitalization and even in empowering digital competence, we have really to be honest that we have additional challenges to overcome in the communication, even the process, even without the digital support, but we have to introduce them multimodal. And this is what I really love that we have to underline in this wonderful panel discussion. So we just talked about the possibility how to provide education training as one of the key elements, embedded in the socio-cultural context, what Tanya really wonderful already addressed. And the second topic is how to develop coordination mechanism among stakeholders in healthcare education, because there are so many activities. Some of them, they've been repeated, some of them have been forgotten, but some of them have been ignored. So that's really the challenge. And I think that's even one of the main tasks of the World Health Summit, to fix it and to be honest, to bring it in a holistic approach. And that's the reason why I like to ask you first, as a clinician, what is even still in a new evolutionary process, because if we touch a woman as a doctor, as a nurse, as every caregiver, this is global health. So what is your response, Sarah Nasser, to this, especially with the backbone of the woman, where have not the best environment for all the sociocultural things? So what we can demand even from the stakeholders.
Thank you very much, Professor Sehuli. Again, just waiting for the noise to go. Yeah, good. Okay, excellent. Thank you very much. No, this is certainly a very important point. So generally, progress in research and development and knowledge about innovative patient management and diagnostics, as well as healthcare education, doesn't transfer very easily from the global north to the global south. And you said that obviously there is a lot of activities, and we were just talking about this, that most of the activities are fragmented. So there sometimes is a lack of connection, or there's similar projects that are happening in parallel, and it is important to coordinate, to have a mechanism where these efforts are coordinated and mainstreamed to be as effective as possible. And certainly a strong and active partnership between the private sector and the public sector is very, very important. And I think as a clinician and in medicine, this is something we always kind of are relatively reluctant to do in terms of a partnership with the private sectors. But we've noticed in our projects that this is really key, to have an active and honest dialogue between private sector and the health industry as such, in order to provide platforms and hubs for coordinating global health activities at a national, regional, and at a global level. In addition to coordinating these from a transdisciplinary approach. So physicians are important, but nurses, midwives are part of it. The social cultural sciences, nutritional sciences, and as well as medical students and academia is very important. So we need to involve academia, and one of the main points is to involve the younger generation. And Murat also touched on this, as well as Tanya and Rupa. It's about involving medical students from the beginning and making sure that global health is part of the medical curriculum from an early stage, in order to grow the importance of this subject through the generations. And as such, we will accept that healthcare education is a global responsibility.
Jean-Marie, I'm always impressed what WHO is doing, and we are really proud as ESGO and even as Charité have so close relationship to you. Thanks to Andreas again. But how we can use your answer with a background of the crosstalk with other diseases, because everybody is talking about holistic approach, but nevertheless, we have one announcement following the next announcement. What is your experience? Your so huge experience. So how we can make really the significant step to coordinate?
Thank you very much, Jalid. Sure that coordination mechanisms among stakeholders in healthcare education must be considered at least at 3 levels. We cannot focus only on global challenges or global mechanisms, ignoring regional and national level mechanisms. So allow me to elaborate a bit more on these three-level coordination mechanisms among stakeholders. First of all, at national level, we should accept a government-led and inclusive processes. Health education sector coordination mechanisms must be government-led. Again, I'm insisting on this alignment. Let us, countries, be in the driving seats, and we come to support them. These mechanisms need to ensure the participation of all relevant stakeholders involved in education development efforts at national or local levels. Sarah talked about the public and the private sector. All sectors should be considered. Second, we should also avoid duplication by building on existing structures. To the extent possible, health education coordination should build on existing national, local structures and mechanisms, and most importantly, on private-public partnership. Duplication of efforts through the establishment of separate or parallel coordination structures and processes should be avoided, whether within the health education sector or across the SDG agenda. If we talk about coordination, we shouldn't forget the 2030 agenda. Everything now we are doing on coordination at global level, at regional level, or at national level is to fulfill our commitments towards the 2030 global agenda. The third one is a system-wide approach. I heard about it when I think it was Rupa talking. Existing health education sector coordination mechanisms and processes will have to be strengthened or adjusted as needed to capture the greater ambition of the 2030 agenda. This entails a truly system-wide approach that includes both formal and non-formal health education and training. We were advocating to include academia, but also non-formal health education should be part of it. Full consideration must be also accorded to relevant structures and processes in decentralized systems as appropriate. The fourth area I would like also to touch on is beyond the silos of health education sectors. National and subnational coordination mechanisms need to avoid a silo by going beyond health education departments to include, where possible, other ministerial departments such as education. We should not confine ourselves to health. We should also work with education. We should work with the youth ministries. We should work with the social affairs ministries, labor, planning, and finance, ensuring appropriate coordination mechanism. This is necessary to ensure high-level political support, intergovernmental cooperation, and also adequate funding. You know, we are moving towards universal health coverage, and this dimension should be taken into consideration. The fifth area for a national coordination mechanism is to ensure linkage with other broader SDG coordination. We should not limit ourselves again to SDG 3. So these linkages must also be ensured between the national coordination of health education with the broader national coordination mechanisms for the overall SDG agenda. That's what I'm recommending at national level. But when now we move to the regional coordination mechanisms, this will develop effective and accountable multi-stakeholder partnership and a shared institutionalized strategy to support implementation at country level. To support implementation at country level. Regional actors to develop collaboratively plans and to monitor, review, and report on progress. That's our role. The regional coordination mechanism can also play a critical role in facilitating a life course approach to conceptualize integrated prevention and control interventions. Last but not least, at global level, how our coordination mechanisms of health education should perform. We should be working within, again, the wider 2030 agenda for sustainable development architecture. It is the totality of the relevant structures and processes at regional and national levels. The coordination mechanisms will take the form of an integrative, multi-sectoral platform. I will come again on this platform later on. All coordination mechanisms work by generating three integrating conditions. First, accountability. Second, predictability. And last, third, a common understanding so that we can share perspective about the tasks. That's what I would like to share with you. Thank you very much, Jalid.
No, I think that's very helpful. And because I think there's no doubt that volunteering is very helpful. And that's even my task to Murat. So we are fighting, and I'm very impressed by your personal engagement, how you bring it to even to doctors and to clinicians who are really trained to make acute, because what we talk is about prevention, secondary, tertiary prevention, and they are not paid by their departments for this. So what professional structures we need to be really sustainable, Murat?
Hello, Jalid. I was a director in the Ministry of Health in Turkey. And really, I have two publications, how many trainings and educations I have done. For example, just in palliative care, hundreds. But, you know, my experience at the end, what I learned is nothing, because the people is working here like a GP and learn some sort of palliative care, and you deserve that he will be the future. But 2 years later, we become a gynecologist, something like that. And you have to continue the training in the GP area. So in my experience, the real trainings is done by doctors' societies, nurse societies, GP societies. So if you make the training centrally from the government, the interest is really low. But today I'm a gynecologist, a member of ESGO, and I really follow my society, my professionality. This means that the core training should be done by professional medical societies. But these societies have some power on us, on members, on professionals, but is limited globally. So we need 100% governmental support. So at the end, my idea is the training, the modules should be done by the societies, but with the support of the government. Because without governmental support, you know, it does not have a value. Nobody gives me a, you know, value if I say that I have been attended to 10 ESGO Congress. I have to be acknowledged by my government in my country that this guy is doing a good training. So we did ESGO, in ESGO, a lot of training for young people, NGO network, for teenagers, engage ESGO teens, for patients, engage, so patient, teens, young doctors, and for professionals, e-academy for the doctors. But at the end, we want professional gynecologists to work in Europe, homogenization. And we know that half of the countries in Europe does not have official certification in gynaecological operation. So what I mean, at the end, we need the government, EU, WHO, and without them, it's nothing.
Yes, thank you very much. I think it's very important that we even use the experience. And that was one, for me personally, the first lesson I learned from Andreas and the colleagues, that we have to involve the government and even to visualize our activities to the government, and even to visualize this to the community and to the citizens and the people, and even to the countries where we like to address. So Rupa, what is your answer based on your experiences?
So building on, we're just gonna. Great. So building on what my colleagues have already said, I think there's a lot of power in networks. Women in Global Health, as I've mentioned, has about 40 chapters around the world. We've grown from 2015 really to bring women from all different backgrounds. So in our movement, for example, we bring health providers, physicians, nurses, community health workers, midwives, but also women working in public health, women working in government, in the private sector, all under the umbrella of a common network where they can advance gender equity in global health, and men are also welcome as allies. So the first is there's a lot of power in networks, but for a network to be effective, it needs to have a common goal, a shared agenda. So as mentioned by some of the colleagues here, that we need to connect with other health professional associations. I'd say we need to go a step further than those that are recognized globally as health professionals, is to actually also engage community health workers. When we're talking about global health, majority of the world's population is actually receiving care from community health workers where there's the greatest need. And they are often not at the decision-making table. They're not seen as formal part of the health sector. But take a look at a country like India, the ability to test, screen, and vaccinate the world is dependent on frontline community health workers like ASHAs. And so, when we're talking about the women's health agenda, whether it is getting diagnostics, screening for cancer done, whether it is actually doing therapeutics or treatment or management of chronic care itself, these community health workers are going to be really, really critical. And as a physician, I wanted to elevate this because I think it's easy to turn to physicians first. We're well organized. We are often the most influential in our governments, and our professional associations hold a lot of power. So we have a responsibility to use our platform and bring the other health workers with us. The second thing is, really also having a shared agenda. As mentioned, we tend to approach, especially in global health, but also in health at the national level, in a very siloed way. Many of these diseases intersect. As someone that sees patients, I never have a patient with just one single active issue. It's always multiple diseases intersecting at the same time with their social determinants of health, with everything else that's taking place. So I think we do need to break down these silos. And for the women's health agenda especially, it would be helpful to have a reset, a refresh of not just strategy talk, but what is our roadmap of action? What's the shared agenda that needs to be happening at the global level? And then finally, the third part I'd really like to emphasize is that these global conversations are great as someone that's very active in the global space, but we need to get to the local, and that's a message that we're hearing over and over. My co-panelists have talked about, and it's great to hear some of the work that Sarah is doing in countries. Tanya, the survey that you guys did, really impressive that you guys were able to reach more than a couple 100,000 people to really get those local perspectives. But our challenge of success is not going to be the outputs. It's really going to be the impact at the local level. And one of the things that Women in Global Health has been able to do, and we're not the only group, but there's many women's organizations and movements that work at the local level that are closer to the needs of women, and also seeing women as agents of change, and really working through those networks and bringing them into the agenda of from diagnosis, treatment, management, but also engaging the broader advocacy agenda, because at the end of the day, we need governments to prioritize women's health as a top area of investment in their health system. Thank you.
Thank you, very valuable. So Tanya, what is your impression?
Yes, I think Rupa, you just you took a lot of the words right out of my mouth. I completely agree with many of the points that you just made. And as I was approaching this particular question, I was thinking about practical solutions that I could add from the perspective of the Global Women's Health Index, but also from the perspective of Hologic as one of the companies that provides significant machinery for breast and cervical cancer screening. I'll keep it really simple because I think a lot of what I was going to say has already been very well articulated by the previous speakers. So I'll keep it to maybe three key points. The first one is we would recommend that if we're going to align and produce some centralized mandates or upheld guidelines, that coordination of the global response for women's health, as well as the coordination of education through professional bodies. Coordination must come from alignment towards common goals. So we have to have those goals written down. Without common goals, and then without common data, the unified accountability for action is really difficult, if not impossible. So common goals and common data. We know that there's that lack of data, which is why the Global Women's Health Index came to the fore. And it's why Project Health Equality can equally play a pivotal role. Both are a source of robust and reliable data, but also a framework. So I would offer that as a starting point, a practical starting point for us to consider for how we might make the next step to drive improvements in care thought, delivery mechanisms, or resourcing. The second is around tailoring healthcare provider education to the needs of women. To really do that, again, we have to come back to the data. We have to understand the needs of women in countries when we're creating these efforts. If we do that, if the Global Women's Health Index can help governments and healthcare systems, then we will produce the education programs which fuel then the future healthcare providers. The next piece, I think, is some elements that come out of the index around women and women's education. And there was three key elements that we felt was really highlighted by the index. One was detecting deadly diseases early. The second one was keeping her in school, driving education for women and girls around health and health options to help them engage with health programs, build trust, remove hesitancy, overcome misinformation. The second piece of that, though, is driving solutions that broaden access to preventative health and screening programs. And that is to increase training to physicians and nurses in country to support these activities. And this is where I double up with Rupa. It's including the adjunct specialties that are needed in order to support women through the continuum of care. For example, radiographers, cytologists, colposcopists, just to focus on those things that are breast and cancer screening related. If we do that, and many of them are women, in turn, we're keeping her in school. And so we're creating a very positive, virtuous cycle, both for the healthcare care delivery system, as well as for the women that it treats. I have other practical recommendations here, but I think I will pause because so much has already been said and I don't want to speak for the sake of just talking. So I'll hand back, I think, Andreas, I hand back now, and I look forward to the next question and adding some additional context there.
Thank you very much, Tanya. It was fantastic to follow your views from a data-driven approach and to think about how we can integrate various aspects of women care, healthcare excellence, and who are the stakeholders. And I would like to now come to this last section of our fantastic panel discussion, which I would like to start with one question, the first question which comes from the virtual audience, and somebody who asked us, and I would like to hand this over to you, an example, a practical example of a successful, let's say, coordination mechanism for education. So I would like to ask Sarah to start with her talk on those third questions, keeping in mind that we would like to respond to that question from the audience. Is there a success story you can integrate? Sarah, over to you.
Thank you, Andreas. I love this question. Concrete examples are always very good for clinicians. So one of our projects that we're actually doing at the Charité, which you all also kindly mentioned at the introduction, is the iStark project, which is a digital trans-African network for improving the healthcare of women. And one of the things we do is regular monthly tumor boards. So we are cooperating with the healthcare industry, and we have once a month a tumor board, which is a virtual meeting where experts in gynaecology, in gynaecology, in pathology, immunology, radiology, and as well as trainees get together via Zoom from the partner institutions. So from Berlin, from us, from Mali, from Morocco. We also have other countries that join the calls at times. So we've had colleagues from Ethiopia, from Guinea, and we will soon have also colleagues join from Botswana, as well as the North African regions, mainly Egypt, Algeria, Sudan, and the Middle East as well. We get together on a Zoom call, and the colleagues or the partner institutions present specific cases, patients that they are treating in their institutions. They show pathology slides, they show CT, MRI, and ultrasound images. And they submit the cases beforehand, we review them, and then we discuss our recommendations. So we have a panel of experts globally sitting at these calls, interdisciplinary, and the pathology slides get reviewed by a pathologist prior to that. And we discuss recommendations for how to either treat this patient. So if the question is about treatment, we will discuss treatment options and recommendations based on the WHO as well as the European guidelines. And we also discuss sometimes diagnostic, further steps. We discuss prehabilitation prior to surgery. And there is a very vivid discussion, and these tumor boards have grown in the last 2 years. We have been doing them over the last 2 years. They have grown. We present about 6 to 7 cases within a tumor board on average, and we have up to 30 participants at each tumor board. The discussions can get quite lively, and people are very passionate about treatment decisions for patients. And we're also inputting all the cases into a software, which is also provided by our health industry cooperating partner. And so this allows us to slowly create a database of presented cases, the outcome, and whether our recommendations have been implemented. And if not, we follow up at a later tumor board to see what's the problem, why was it not implemented, were the resources missing in that particular setting, or was the patient lost to follow up? What other needs are required? Is it that patients, that there is no database locally for them to follow up patients, or is, for example, was the recommendation radiotherapy and the patient couldn't get access to radiotherapy? So these are some concrete examples, and we're gathering cases. We have a total of 84 cases, mainly patients with ovarian cancer and cervical cancer from the regions, and we're now doing the follow-up. So this is one of our concrete examples.
Thank you so much. It's inspiring us for doing more. And I would like to hand over to Jean-Marie. Practical examples, success stories are the starting point for more, for implementing, to think about what next, what are the next steps. Jean-Marie, do you have a success story from your region in terms of education, what we could give as lessons learned to scale it up? Over to you, Jean-Marie.
Thank you very much, Andreas. So with regard to women's health, and particularly the area on which I'm working, we're not fully involved in supporting training and capacity building. We did it occasionally in a couple of countries, but we didn't put in place a regional framework for improving the capacity of the healthcare providers focusing on women's health. But for the future, I think this kind of discussions is very, very important. And I would like to make a suggestion based on what I heard and what the organization I'm representing today is doing. This recommendation is to go for an integrative multi-sectoral platform managed by a global task force, and these should be established to impact women's health throughout life course by supporting synergistic, sustainable, and gender and content appropriate public health interventions. It's important because looking at the panorama of the experts today, focusing on different areas, we should try to break the silos. And so a package of 5 strategies should be considered. The first one is to influence the setting of a global political agenda, thereby ensuring high-level political support for action across sectors, not only on cancers, not only on cardiovascular disease, not only on gender-based violence, but across all sectors. Second, we talked about data-driven approach. So I think evidence should be generated to make the business case for women's health needs and showcase the relevance of proposed interventions for the goal of partner ministries, but also other stakeholders. We should go further and prepare a costed joint work plan and earmark funds for its implementation. The mechanisms also need to develop a set of process and outcome indicators. So everything we'll be doing should be monitored, particularly the implementation of this joint work plan, and report back to all stakeholders, particularly the supra-ministerial authority. I'm confident that international development partners, as well as civil society organizations, will support the work of the multi-stakeholder platform through specific technical and financial inputs. And we need to explore and identify the best means to engage with the private sector, which should play a critical role in this platform. That's what I wanted to share, and thank you very much.
Thank you very much, Jean-Marie, and I would like to hand over to Rupa to join in with probably a success story, but also what could we do, and using the Jean-Marie's framework of a global task force. What do you think about that, and would you join that? Over to you.
Thank you, Andres, for the question. I have to say there are so many success stories out there, so it's very hard to pick. But some of the examples that I'll try to pull from is things that are going on in the Women in Global Health Network. One example is during COVID-19, our chapter in India organized Power Dialogues, which is a means to bring policymakers together with women health workers that are at the front line, as well as women with their health needs, all under one umbrella conversation. They actually hosted 12 of them in partnership with the World Health Organization in India to again connect policymakers, technical experts, as well as those that are most affected by the health access issues and those that are responsible for providing health access issues, to talk about how they could actually address these issues of access in COVID-19. And as many of you probably know, a recent WHO survey looking at access to essential health services, at least 60% of the essential services around family planning were disrupted, countries reported responded, the survey that responded. So it just shows you that, you know, this is an example of like one where networks can come together, where women's movements can work very closely with established global partners, but also with policymakers and other technical experts. Similarly, in Somalia, for example, we've learned earlier in the pandemic that the data that was being disaggregated by the country was not disaggregated by sex and gender. So our chapter there mobilized. They actually did a social media campaign, but also a local radio campaign to get the intention of the ministry. And then they were invited by the ministry to start developing mechanisms for disaggregating data by sex. And so now Somalia has some partial sex disaggregated data around COVID-19. So that's another example of a successful story. But, you know, the question that you also asked, Andres, is where do we go from here? And, you know, would we be interested in an initiative that you've mentioned? Of course, I think, you know, the initiatives that bring multiple partners and multiple stakeholders together to have a shared agenda are the most effective. If we all keep trying to address these large global problems at the local level individually and not really pooling our resources, the knowledge, the learnings we're gaining, we just will not chip away as fast as we need to. And so, you know, I've kind of mentioned my points throughout the conversation today, but, you know, going back to it, we need to continue to change the narrative, start viewing women as the leaders. They are majority of the health and care workforce. They provide care to 5 billion people. And without women, there would be no health services or health systems. And I'd like to see that any future conversation about women's health actually includes a women's leadership dimension as a critical part. And I've heard that, you know, my colleagues here, many of you are working on women's leadership as a women's health agenda, but I'd like to see that a global shared common agenda. We also know that women are often clustered in lower status jobs. It means that they're held back. They face bias and discrimination, violence, harassment, and it's an address. We need to address power and privilege and the abuse of it, especially for women that are responsible for providing care to our communities. And if we have to make any stance and really build the capacity of the health workforce, they need to be enabled. And I've talked a lot about the decision-making aspect of it, but how we will see whether they're truly enabled is if we start seeing women in equal numbers at decision-making at the national level, the sub-national level, at the community level. And there's a lot of work to be done. And we've seen that in the pandemic, because of women's expertise being sidelined, we've seen gender-blind policies, examples of the fact that many countries have reported disrupting access to family planning, or women were being told to give birth at home, and pregnancy does not stop in pandemics. And if women were in equal numbers in COVID-19 task teams, it would have not been seen as an optional thing. I'm not trying to discredit the men here. The male colleagues, obviously on today's call, are champions of women's health and are our strongest allies. But I think it is about how we collectively move together the gender agenda for all genders, and it benefits everyone. And then finally, we cannot improve health services without taking an intersectionality approach. And I think, Tanya, you mentioned a bit of these things of how do we reach some of the hardest to reach women. We need to have the data, and we need the data of the most marginalized. And we also need the data of who's, what the privileged women are experiencing too. But it's about success in data is when we can reach the invisible women. And this needs to be by economic status, it needs to be by caste, it needs to be by race and ethnicity where that applies, as well as the sex and gender aspects of it. And through that, we will really be able to hold ourselves account. So all of these things are critical ingredients of where we need to go next. What I'd like to say is that it needs to be a shared agenda, and I really do hope that we can, continue to move the needle through finding that common roadmap forward. Thank you, Andres.
Thank you so much, Rupa, for that comprehensive view on women leadership. And I would like to bring this into now our next speaker, Murat. How do you see?
I can see you, but cannot hear you. Anyhow, how I see this situation, yes. Yeah, Andreas. For me, actually, we are talking what we can do. We are talking about some negative stories or scenarios, but let's be positive, because we have some opportunities that we can use together. the biggest opportunity is WHO, Cervical Cancer Elimination Program. So this can be an umbrella or pilot to start all these trainings. Second opportunity is European Union Cancer Beat Plan. I don't know if you have heard, but there are now dozens of billions euros in these projects. And lots of these projects are related to education and training of the people and of the doctors. So all societies can, use this opportunity to apply to European Union, get some grant and use them. From the ESGO part, gynaecological oncology, we will in the prevention committee, we target two important European EU Health for project now. For example, one is on HPV vaccination, how to improve the coverage in the vaccination in different countries. And the other is the quality assurance in the cancer surgery in gynaecological oncology. Let's see the results. But as a society, we are ready to teach patients, to teach doctors. How? We have the experts, we have the papers, guidelines, and we have the e-academy modules. So everywhere you can go, click and learn. And I hope the societies should be ready. Similarly, the patients, the doctors, the basic advanced level training modules. And once the time comes from the WHO, from European Union, we will be ready as a society to teach cancer screening, to teach cancer diagnosis, to teach cancer treatment in gynaecological oncology. Similarly, other societies will do or doing the same. So the next step is to search for WHO and European Union grants and to be ready as the societies, as the doctors. Because today, if you say me, hey, Murat, let's make a training for cervical cancer screening in Latvia, for example, it takes at least 1 year to make this module ready. So the next step is being ready for these inquiries. And I believe as a gynaecology society, we are almost done. We are ready because WHO has started the cervical cancer elimination program and we were very fast. It was, you write the editorial, Andreas, also. It was a wake-up time for us. Wake up. Don't sleep, doctors. Don't sleep, societies. Wake up. Something is going on.
Murat, do you see, just a quick question, do you see a global role of ESCO beyond the European limits? We have Jean-Marie in our panel. What do you think? Could you do something?
I think Europe is not limited, is not starting with Spain and finishing at Bulgaria or Greece. The Europe territory is bigger than this. If you look to the history, Turkey, and then Azerbaijan, Armenia, even up to Kazakhstan, is a European country. Similarly, North Africa, and similarly, immigrants of Europe in United States. For sure, 100% we have it all.
Okay, thank you. Now I would like to hand over to Tanya to give our final statement about next steps. How can we partner public, private, government, international organization? What is the contribution from the private sector?
Yeah, indeed. So certainly I repeat the piece around coordination needs to come from alignment to those common goals. So we'd be very happy to participate in supporting, as you referred to, any global guidelines. There's certainly a role for us to play in being able to lend. Oh, can you hear me? Oh, you can? Can you hear me okay? Sorry, my whole computer screen just went blank there. So this, just to come back to that, there's certainly a role for the private industry to play there. Obviously, there's also an element that we do. You asked for some success stories. There's countless hours of education that we put into healthcare provider training, certainly around the technology that enables breast cancer as well as cervical cancer treatment. But with Project Health Equality, one success story just recently has been working with some underprivileged communities in Manchester, really raising the awareness and the education level for women on the street around why breast cancer awareness and breast cancer screening is so very important to them. We'll continue those programs relative to cervical cancer as well in January when Cervical Cancer Awareness Month comes around. I think I've already mentioned the Global Women's Health Index. What I haven't said is that that has now been translated and has been prepared as 15 individual country reports for 15 different countries across the world. I can list them off for you, but I won't use the precious time here to do that. Again, those reports are available on our website. The other area that Hologic is very keen to be involved with and to continue to support is around the most recent activity that we've gotten involved with. And that's with the new Women and Girls Health Project with the World Economic Forum. We're very keen to continue our involvement there with those, with the World Economic Forum and any others that are committed to improving the lives and the health of women globally. And we certainly hope that our involvement will highlight and encourage other organizations to consider how they could be involved in relevant initiatives that help to expand the resource and the influence in this very important area. We're committed to being the champions of women's health. And if there's an opportunity for us to continue to partner with this group or with other organizations moving forward, we're very open to that. And I'd personally welcome the opportunity to discuss it or any of the reports further.
Thank you very much, Tanya. Jalit, I hand over to you as co-chair for some final remarks. Over to you.
I think was a wonderful panel, and we have noticed that that's much more than only enthusiasm. There are so many resources, and we have to empower them and to visualize them. And according to all the other challenges in the world, climate, pandemic aspects, tobacco, there's nothing clearer than in women health and in global health that's not regional, not country-based, not continent-based. This can a single initiative, and that's the reason why I think we have already first step, the commitment, second, to identify the resource. And I love, Andreas, even your idea to show things what are really pragmatic and really reachable in a very low barrier, but nevertheless we need a professional environment, and we need even to empower even the initiatives to apply for the new possibilities, because helping people communicating with women is one thing, but to applying for announcement and for awards or a program is something different. So we need empowerment at all levels, and I think this is really even important step. We can discuss it even in Berlin and with the other groups, how we can use professional resources to even sustainable active involvement of the NGOs, of the academic and non-academic institution, and beyond the profession. That will be my distilled summary. And Andreas, again, thank you personally, and maybe you can give the final words.
Thank you, Jalit. Thank you, dear speakers and panelists, and dear distinguished audience. Unfortunately, I cannot see you, but I'm sure next year we will be in person again in Berlin. I like these three pillars of the World Health Summit: global challenge, global responsibility, and global networking. And I think with our panel, with our thematic preparation of our panel, we have contributed to this overarching goal of the World Health Summit, that we have tackled an important challenge, the gap in education for healthcare providers for women health. And we have also created a momentum of a global responsibility. the societies, the women health, the civil society, the private sector, WHO, governmental support, we see that we are one health, one world, where we can exchange. We need to exchange our experiences and best practices. And I'm really very proud that I brought you together. So this means we do not only have a panel at the World Health Assembly, but we have now opportunity
happened, Andreas. So, but nevertheless, I think it was a wonderful panel. And so let's really try to stay in relationship, because communication is nice, and relationship is much more important, and we will strengthen this. So thank you very much for your engagement, and let's make it pragmatic and start the next step. Thank you very much.
Thank you. Thank you. Bye-bye.